macroscopic level, they exist to kill. They travel, they attack, they hide, they even gather together in defense maneuvers. Pathogens are the enemies of every member of the healthcare team. On Pathogens and PPE, we give you the tools you need to fight these threats and win. So sit back, tune in, and let's make these microbes tremble at the sound of your name.
Hello and welcome back to the Pathogens and PPE podcast. This is episode 6, all about endoscopy reprocessing and where do we see ourselves in the future. I am joined today with my co-host Kevin Anderson, and we will be right back after a message from our sponsors, so don't go anywhere. Everybody, and welcome back to episode 6 of On Pathogens and PPE podcast. I am your host, Jill Holdsworth, and I am here with my co-host, Kevin Anderson. Kevin, thanks so much for joining me again.
Hey, thank you for the invite. Always a pleasure. Looking forward to getting into endoscopy reprocessing. Haven't talked about this in a while, so let's get going.
Yeah, it's a really important topic, and I know a lot of people really struggle with what are we supposed to do? We're having trouble. We don't really know what we're dealing with here and how we improve. So this is a really important one. Before we get started, Kevin, why don't you give everybody just a little bit of background about yourself, just in case they don't already know who you are?
Sure thing. Yeah. So I work with Healthmark, a Getinga company. I am currently senior manager of commercial education services, but practically speaking, my background is obviously with Healthmark and the education team. But prior to that, I worked in surgery, followed by management, followed by SPD and management of SPD and endoscopy reprocessing as well. So that's kind of my background in a nutshell.
Quite the history. All right. So we have 3 amazing guests today, and I'm going to give them the chance to give a little bit of a background for themselves as well. I am going to start with Jennifer. Jennifer, why don't you do the same? Tell us a little bit about how you got here.
Thank you, Jill. I am very excited to be here. I've had a very long history in endoscope reprocessing. I started my healthcare journey right out of high school, and I was kind of directed into sterile processing before I knew anything about it. And then I did that for a really long time until I decided to take the jump into infection prevention. Then I started expanding my world. Thanks to social media, things like LinkedIn, my community just exploded. And that is where I met you, Jill, for the first time, is through one of our social events or one of our conferences that we always end up at together. Now I focus on endoscope reprocessing primarily as my new role. And I use a lot of my infection prevention training to help guide new processes, make sure that we are maintaining the standards that we hold ourselves to. So thanks for having me.
I'm so glad that you mentioned networking and social media, because it really is such a powerful thing in these industries. So use it, network, meet people, and keep in touch with people, because it is truly so powerful in all of these industries that we work in. Emily, you're next.
Oh, hi, Jill. Thank you. Also excited to be here. I started as a surgical technologist way back in 2004. And at the time, I was working in an operating room where we had a small satellite CSS, and it was actually the surge techs that went back and cleaned scopes and processed instruments. So I really took a lead in that role. And then I was pulled to go look at clinics associated with the facility where I work and look at instrument processing in the clinics, which is a very different beast than it is in central sterile within a hospital. And from that role, I was pulled into infection prevention. So I was a practicing infection preventionist for several years, still maintain my CIC certification. But now I am part of a team. We're called the HLD team. We're part of clinical epidemiology. And we go out and complete competencies and education for the staff in the clinics that don't have CSS staff. And we also serve as a liaison for the clinics that send instruments to CSS to ensure proper point of use treatment and transportation.
Great. All right, Dyan.
All right. Hey there, I'm Dyan Darga. I am also with Healthmark, a Getting It company, and I'm brand new with Healthmark. I've been there for about 9 to 10 months. Prior to that, and I'm a clinical education specialist for them. And then prior to that, I was in endoscopy leadership and management for about the last, 10 or 12 years. And I've been in endo for about 20 years altogether. And so background is, nursing. And yeah, so I've had fortunately been able to kind of live all around in Atlanta and also in Michigan. I worked in Florida for a little bit as well. So I've had the opportunity to see how a lot of different endoscopy departments operate. And that's given me, I think, some pretty good perspective on just seeing how different places work. And now I get to do even more of that when we do endoscopy-focused assessments and go into different hospitals that request us, to make sure that they're operating up to standards.
Fantastic. Well, I can't wait to pick your brain a little bit during this podcast on all of that experience that you've had. I'm going to start back with Emiley with this first question. What do you feel like some of the common challenges with endoscopy reprocessing are that we're seeing today?
One of the challenges that comes to mind is the volume of procedures that are being performed and the demands on staff and sort of the end users with the endoscope not really understanding all of the steps that have to go into reprocessing. So I feel like there's a lot of pressure on the techs as far as turnaround time for scopes. Manufacturer's instructions for use is always a challenge. Sometimes they're too vague. Sometimes they're overcomplicated. Sometimes it's hard to get the right instructions for use if they're not readily available. So those are some of the common challenges that I thought about.
What about you, Jennifer? What do you have to add to that? Those were really good points. Ones that I can identify with easily. The volume, training. I was one of those people who came in every once in a while to help out in endo, but didn't really know everything at the time. So I can relate to that. But what about you, Jennifer? What do you got to say on that?
Yeah, that's probably easily the top one or two issue that we see is the high turnover too of staff. Mm-hmm. Folks getting burned out doing this work because it is so fast paced and there's such a demand on perfectionism with this work, but yet there's little to no training or onboarding, and they're thrown into this environment that can be very stressful, and there's no glory to the job really. It's one of those thankless roles. It's incredibly important, but it doesn't get the attention or support that it needs. So staffing is definitely right up there. But the other thing that I see is the inconsistency we have with training new associates for this work. There's still not a standardized onboarding process for education around why we do what we do and why it matters and the how and the why behind reading an IFU. Some folks don't even know how to really read an IFU and really digest it and understand it, especially when they're 85 to 120 pages like a lot of the vendors are today. So that true lack of deep training that we need at the tech level that's doing the work, I think is definitely one of our biggest challenges, is that education piece.
And one of the challenges that I've also seen is just the who is doing the reprocessing. There's some places that have GI labs that don't even have actual technicians that are trained for reprocessing, like that's their job, that's their specialty. They have some of the nurses or the folks that are doing the actual procedures that rotate through the reprocessing room once a week. And the last thing that they want to be doing is reprocessing. So that they're not owning that. That's their worst day of their work week. Are you guys seeing that much where you guys are?
You know what? I never hated it. I liked it. I would just close myself off in that room, turn on my music and hit it. But so I never minded it too much, but I definitely agree that it's definitely a challenge. We have, unfortunately, I'll just kind of call it how I see it. We have some of the lowest paid people working in the most important area of the hospital. And for me, that is kind of the biggest struggle. And then the other thing that I noticed was that we seem to keep adding reprocessing elements, visual inspection with lighted magnification and a 10-minute dry time. But there's not always, we don't always have the infrastructure, and, the changes on the turnover expectation does not necessarily change. So you're putting, as you guys have said, more pressure on the technicians to just keep going. And there's an endpoint to that, to their, willingness and ability to do that on a day in and day out basis. So.
Well, I love that you mentioned how the department is structured. Like, when you consider all the things that we found in the updates of, say, ST91, as that was pretty recent now, and you alluded to some additional steps that are necessary, which are very critical to the safe reprocessing of endoscopes. However, when I think back to my experience in our tiny little endoscopy reprocessing room that was, oh my gosh, it was retrofitted into like 2 adjacent closets. I mean, there's literally no room for anything. There's not even like a small table to lay out the scope to inspect. Mm-hmm. And really, there should be an inspection station and there's so many things. I can relate to it with an SPD point of view as well, because often the SPDs are retrofitted into areas where they used to serve food or things like that. So a lot of people are dealing with this same challenge that you just mentioned, just having the space to configure, make it like efficient to add all those additional steps. And the other component that I see often is just not having the inventory. Now that's a whole nother discussion, but a little rabbit hole there. But to your point, it's very common to see issues just within the department layout itself, and not being able to accommodate those extra steps the way they should be done.
Mm-hmm. And we as an industry have not been able to take the time to present these new time challenges to the overall block flow. So physicians are still used to working in 15-minute windows of time, and that next 15 minutes, it's a whole new thing for them. And we're still spending another 30 minutes on a scope process where 15, 20 years ago when the block times were built, that process maybe took. So we've never been able to meet in the middle.
It really is such a good point that you guys are making, that over time we've added so many additional steps and safeguards and things that we have to do, but we've never really increased staffing or the amount of people that we're using to do these steps. And I don't know if there's been staffing studies or things like that are needed, but something like that should be done every time that we say we need to do 10 extra minutes of drying, or we need to do this. We need to add these things to the process, because we're just burning people out more and more and more, or we're requiring them to cut extra corners in some other part of the process, which is making it even more unsafe.
Believe it or not, I just was looking at some studies, and I guess back in 2017, Olympus said that it took about 57 minutes on average to reprocess an endoscope. And more recently, Corey Ofsted timed it at 90 minutes, which is mind-boggling to me. I mean, that is a really long time. I'm thinking maybe it's an ERCP scope, but for a regular scope, that actually does seem like a long time, but that's what we're dealing with. Like you said, it used to be so fast. It used to be a 10-minute sink wash and maybe a 12-minute soak in OPA, and you're out and you're done and you're back, it's back around. You didn't have to dry anything.
Drying wasn't even a concept. We never touched a dry scope because it was wet, and then back to the next procedure.
So true.
So far have we come.
Exactly.
So moving on to kind of a different topic, do you feel like we've gotten better at anything? Have we moved forward on any part of the reprocessing of endoscopes in this crazy process that we've just kept adding steps to? Are we moving forward with anything that, in your opinion, anyone can
I do. I think that we are moving forward, but I feel like it's very slow. It's very slow progress. I was at a conference not too long ago and they said practice change takes somewhere between 17 and 20 plus years for it to actually occur, and in medicine especially. But that is mind-boggling when you think about it and how long that really of a time it is. You know, it's multifaceted. You can't just make a practice change based on one study that you find out about, right? You want to make sure it's a tested and true kind of situation before you're making that change. And then, you know, the larger the organization you are, the less agile you are to, you know, decide to make those changes and then implement them. And then you, of course, have to teach the staff and make sure that they understand the whys behind it, or else it's never going to get bought into. They have to understand why the change is needed. So lots of education, and it is a slow process, but it can happen. It does happen. It's just slow.
So we have the structure from AAMI ST91. It did get rid of a lot of that gray area, the confusion, especially around the definition of high-risk endoscopes. I think we're going in a really good way around the structure, but implementing all of those structures takes years of planning and foresight on an organization in terms of capital equipment as well. And if you want to fully absorb and use ST91 for 100% of its work, you're looking at revamping your entire endoscope inventory to make sure that it's compatible with the methods we want to do tomorrow. And the scopes that you've been processing today might not be viable to be sterilized in tomorrow's goal world. So it's really, I think there's a huge financial impact for organizations to move to this gold standard that we all envision us going to. It's a very slow road. And Dyan, you're right. Change takes a very long time. And it seems like there's a key with the number 7, because you have to tell someone 7 times about something in order for that change to stick. So imagine presenting a case study or a request for construction or capital to your C. You have to do that 7 times potentially in order for that momentum to keep going enough where you actually see that change. So it's a very long road.
That's such an interesting point that you have to say something 7 times. I'm wondering how many times I've asked for the right drying cabinets. Like, can we have the cabinets when you talk about trying to be compliant with ST91? And they see the price tag of a true drying cabinet with the connectors for the channels and everything. And they're like, oh, I don't think we need that. And then we need instrument air to go with it. And I'm not sure we can retrofit. But as I think about where we've gotten better, some very specific facets come to mind, like point of use cleaning, which I've mentioned before, and transportation. Going back to all of my experience, point of use treatment at the bedside was not a thing when I was cleaning scopes regularly. And the things floating around in the sink and the things that came out on your first brushing we just don't see them now. When I'm observing cleaning or doing it myself, I feel like we've come a long way. I also used to go down to endoscopy and get a scope to take to the operating room, and I would put it in a pillowcase. Like, that is just so bad. And now we have actual transportation bins and people are using them, and we're clearly marking them as clean or dirty because we would often put the scope in that, just back a pillowcase. Like, these were the things that were being done. So I feel like with certain points we really are, but then it is such a good point when I think about how long it's taken to get us, kind of to where we are with these seemingly small changes.
I find it a little bit encouraging to hear what you guys are saying and that you are seeing progress. What I think is really important to take away, at least what I'm taking away from what you're saying, is that, yeah, it takes a long time, but what's also really important with a document like ST9, it's the standards and guidelines. There's not a how to implement the standards and guidelines attached to that. And that's where people struggle the most. And I think what's really important is that people make incremental improvements over time, implement one changeable thing now and then have a vision for the future. You mentioned the drying cabinets. I mean, that's a capital equipment request. I mean, that's got to go through 12 to 20 layers of approvals, and all those people are going to be on vacation and, whatever. It's going to take forever to get that. But the point is to ask for it and justify the request and get it on the list, and in the meantime, institute some other practices that you can implement, right? But all very encouraging, I think, to hear what you're saying. And I agree with you, especially the point of use stuff. That's something I've seen personally get a lot better throughout my career as well. Kind of switching gears again, what do you feel we need to make more progress to make patients safer? What is your opinion on that? And for this one, why don't we start with you, Emily, since you finished the last one?
Okay, sure. I think what we need is a culture shift. I think we need to be able to speak up when we see something that isn't quite right, or be honest about something that just isn't working. I feel like at the technician level, they get a lot of things thrown at them. Like, you need to do this, you need to do this. And I don't see a culture where their opinions are necessarily respected all of the time. It's like, you need to do this, figure out how to do it. But their input isn't always there. So a culture shift would be helpful. Let's speak up. Let's make sure everybody knows what goes into processing, how we can't cut corners. And beyond that, I would say we can do better with standardization. There's so many different workflows, so many different individuals bringing sort of opinions into the process and different products. So standardization, I think, is something that would be helpful moving forward. And that would help the techs feel more confident that they're doing it the same way every time.
Emily, just a follow-up question. Where would you ideally like that standardization to come from? Are you thinking organization level? Are you thinking standards level, or some sort of national guidance level? What would be most helpful?
My first quick answer would be at the organizational level, because that's where I feel like I personally have the most impact. But my impact comes from knowing the standards and knowing the guidelines. And so I feel like it kind of goes both ways. The organization has to be open to looking at the guidelines, and then the organizations creating the guidelines need to help us implement a little bit more, maybe some clearer guidance from the standards level of how to implement would be good.
Jennifer, what do you think we need to start paying more attention to, working on, or improve on?
I'd love to see more collaboration at the facility level. We still have a lot of bottlenecks when it comes to department leaders communicating with the local infection preventionist or the local quality team. I think we could do better around more eyes on this work, not so much auditing, but the understanding of the work, and just going in there and checking the log sheets to make sure that they're filled out correctly, that the steps are actually being done. And then taking that and changing, like Emily said, changing that culture to where people want to do this work, not feel like they're forced to do this work, and then they're caused to cut corners because they're pressured for quick turnover. I think the more eyes we have on this work, the better chance we have at having larger conversations at the organizational level. And from experience, I've been building my program for over 2 years now, and it's still not done. And there's all these tentacles that you identify when you start breaking down this program, and you have so many things to talk about. If your C-suite team isn't understanding what your goals are and what your barriers are, the chances of you getting to some sort of resolution are slim. So I think collaboration for me is huge.
I think that's such a great point. We've been doing a better job of collaborating recently. So we actually have our accreditation partners rounding with infection prevention in our endoscope reprocessing areas. And having accreditation has really helped us get more of the focus that we need in the space. That's a great point.
Yeah, I find that those folks are really good at advocating for needs as well to the C-suite and to folks who have some control over funds and resources that you might need. So I think that's a really great idea. What about you, Dyan? What do you think?
So those were excellent answers, I think, to that question, and definitely more of like a high level look. My head immediately went to just reprocessing steps, I guess. So for me, I think as far as what we can do to try to make patients more safe is, of course, as we've been saying, follow the reprocessing steps as best as you possibly can, because each one lays the foundation for the subsequent step, right? But if I had to pick like one step, for example, that I think is the most important, or what I maybe not the most important, but one that I see we could be making more progress with, it's the drying step, because bacteria lives in that water, and if you don't get rid of it, it's going to continue to stay there. So the drying aspect for me is so critical and so important. And to me, it's not that hard of an issue, because drying cabinets are a huge expense for sure. Totally agree with that. But those little machines that you can get that are tabletop machines are not that expensive, and they're usually under most capital thresholds. So, I would absolutely be, buying those up like candy and using those to dry the scopes, because it's 10 minutes, it's filtered, it's like everything. You just plug it in and go. You don't need you know what I mean? It's all filtered. So to me, that's so easy. And it's one of the most important things we can do to try to keep our patients safe. So that's where my head went anyways.
I totally agree with you, Dyan, and I'll say why. It's not because I did a study with Corey and Healthmark, but the drying that's included in the AERs is not enough. And I know that a lot of people think that it is, but our study looked with borescopes inside these endoscopes after the drying, and there were droplets galore. So if you are hanging your scopes after that drying that's happening in your machines, they're wet. And they're wet after hanging for days. So it's not enough. That's all I can say. So I totally agree with you. That is something that we have to do better. And you can't just assume anything. You can't assume that it's dry. And I can't cheerlead enough for using borescopes for everything, because once you use them and you verify what you're doing, you'll find that there's all kinds of things that we can do better. So I'm glad that you brought that one up, because I do feel very strongly about that one. All right. So let's go around now and just talk about, what do we see in the future for endoscope reprocessing? What do we hypothesize or just see or hope for the future? It can be however you want to answer. And Jennifer, why don't we start with you this time?
I would love to see a full transition toward terminal sterilization, supplemented by single-use scopes. And the reason I support single-use scopes is because they really have a place, especially in the duodenoscope world, where if we are treating a patient that is immunocompromised, or they are a host, they are carriers. Maybe they have other things that are transmissible, and we don't want to risk such a complicated device on a patient where we could potentially not get rid of that pathogen and pass it on to the next one. So between the two, sterilization and supplemented with single-use scopes, I think is the way to go. But we still need to master all of the cleaning of those scopes before they get to that sterilization step. Otherwise, that step is futile as well. So there still has to be that pedal to the metal, so to speak, on the focus on the cleaning portion of it, because that will never go away. And even though we want sterilization in the end, we still need to focus on that cleaning long term.
Yeah, great point. Right. Emily, how about you?
Yes. Well, of course, as Jennifer said, the top of all of our minds is, can we sterilize these scopes? And we're moving to sterilization as much as we can, but not quite there for the complicated and longer GI scopes. But as far as what I hope for the future, I think goes back to another point that Jennifer made earlier, which is just more multidisciplinary teams looking at scope processing. So it's not just the endoscopy department, or SPD, but we're really getting accreditation in there. And we are getting the right people to do the education. We have infection prevention. We've got environmental services. We've got everybody that needs to take care of that department a seat at the table and a voice and how to do better. I would love to see that.
What about you, Dyan?
Yes, of course, I definitely agree with the move to sterilization. But I also think in the meantime, since, to your point, Emily, we're not quite there yet. I would like to see a shift towards more automation, and especially with traceability, with scanning, with doing that throughout every step of the endoscope reprocessing process. Like, I think we're going to be starting to see more microbial surveillance and culturing coming up. And to your point too, the shift towards some disposable or semi-disposable technology. I've seen some hybrid scopes where they're like pieces of not just the duodenoscope with the disposable end cap, but pieces of the scope are reusable and then certain pieces are disposable. And I don't know everything about that yet, but I'm very intrigued by that concept. So I'm trying to learn more about that. But I think that's an interesting concept.
Yeah, I think there's a need for just continuous innovation when it comes to the design of these, whether it's single use or reusable, it almost doesn't matter. But a hybrid approach, from single use to reusable to semi-reusable or reusable with disposable components, all that stuff, I think is valid. And it would be great to see some innovation both on the device side and some automation, maybe in the cleaning, inspection, disinfection, sterilization. That would be fantastic. Unfortunately, I think some of the innovation steps, those things take some time. So that's why it's really important to do your best to chip away and get better at meeting the standards as best you can with the resources that you have. One thing I mentioned earlier, and I think this is common, you guys probably see it all the time, is just simply increasing inventory. I mean, it's just trying to add any of these steps, these critical components to ST91 without increasing some sort of amount of endoscopes, whether it's disposable or not. I think it's just like Jill said earlier, I don't know how you do it without putting pressure on people to cut corners, and that's going to undermine your whole process. So,
yeah, good point. All right, as we start to wrap up here, I am going to go around to everybody and ask each of you to give a tip, some guidance, or just what we like to call go and do to our listeners that they can just simply go and implement in their facilities or their healthcare system today, something that can make an immediate impact or something they can go and assess and put into place right now. So I'm going to go around and start with Dyan first.
Yeah, so I wish I had something brand new to say, but I'm going to still go back to the drying, because to me, getting those machines, if you don't have drying cabinets, getting those machines is something you can do. Maybe not today, but literally within 2 weeks. Like, you can do this. It's super easy. It's super fast. And to me, it's so important that I don't think there's an excuse why you should not have. I don't want to see any more of those air hose gun things. I don't want to see people standing there for, they say they're standing there for 10 minutes, but they're not. I want to see these machines in place pretty much everywhere if you don't have the drying cabinet. So to me, this is something that's easily accomplished.
Great. And Emily, you want to go next?
As far as a go and do for the infection preventionists out there listening, I would say build the relationships, ask to be able to get your hands on a scope. Process a scope, process a couple of them, put on your PPE, get elbow deep in some water, and just see what it's really like to handle the scope. I mean, I'm short, and when I process a long endoscope, I can hold it above my head, and that's how I have to keep it off the floor. But I feel like if you've done the work, even just a couple times, you're a better advocate for the people doing the work and what they need. So IPs go out there, and then the technicians that are doing this work, just pause at least once in your day and know that what you're doing is so important, because I know how it can feel when it's one after the other and somebody complaining and something not ready on time or not turned over fast enough. So just know how important your work is. And yeah.
Great.
What about you, Jennifer?
This was hard. I was grateful to go last because it really kept my brain going. I'm going to have to say, read the most current IFUs for your devices. I think go do some rounds and ask your staff to pull the IFUs, because it's shocking to me still today how many people don't know how to find their IFUs for their scopes or devices. And they probably have a stack of the manuals still in the plastic bags in the bottom of some unused cart from 2004. And those are their IFUs. So my encouragement is to go look for your IFUs, make sure they're current. If you don't know where to find them, learn where to find them. Make sure your facilities have access to them if they don't, and read them. And I think it'll be enlightening for those out there that haven't read IFUs before.
Great. And Kevin, why don't you take us home?
All right. Yeah. So for IPs that might be listening, I would just suggest that you just get curious. And I would say to the point where you actually stay in the department and follow scopes for hours of the day, like use a single day or an entire week is even better, because you see the dynamic between different docs, different staff, all the different technicians, nurses, everybody who's involved. If you can dedicate that kind of time and be curious, you're going to learn a ton about the culture and about why things are happening the way they are. That's invaluable. For technicians, I would say take some ownership of your practice, take some ownership of your education, learn about why these changes are being recommended, learn about the studies that have been done. Jill mentioned one earlier, but there are many. All right. So get informed on the whys behind this and check that against your own practices, your own beliefs, and see if you can be part of the positive change in your culture or in your department to make it safer for patients.
Awesome. Thank you guys so much for being on this episode, and we're going to have to wrap it up there, but I really appreciate all of you being on here. This was a great episode and lots of content here. Thank you to everybody listening, and we will see you next time for episode 7.
Okay, thank you all for tuning in for episode 6 of this series of Pathogens and PPE podcasts. We hope you enjoyed it. We had some great guests on this show, and I think you're going to get a lot out of it. So thank you for listening, and please remember to subscribe.
I really liked in this episode how we started off with talking about how the IFUs are so complicated, but then they also can be so vague, because I feel like we talk about that with our surgical instruments too. Sometimes they're too complicated to even think about being compliant. And then sometimes they're just so vague, there's no way that you could even pretend to be doing the right thing because you have no idea what they're talking about.
Yeah.
So I loved how we started off with that, because it just kind of set the stage for how difficult it is to do anything correctly in endoscopy. We haven't even set anybody up for success. So we really have to do better. The future of endoscopy starts at the very beginning with the manufacturer's IFUs if we want to be successful. And they said it best, we're adding steps, we're adding things, but we're not adding staff. So we're just making things harder. So we have a long way to go. This episode outlined that so clearly. So lots of work for the future, lots of things that need to happen to keep our patients safe. I hope you guys enjoyed this episode and that you're going to take those go and do's and go audit, go make relationships better, stronger, and prevent those infections. We will see you next time for episode 7. Keep fighting dirty, and don't forget to wash your hands.
Thanks for tuning in to this exclusive podcast series on pathogens and PPE. For more information and clinical resources to help you fight dirty, make sure to follow us on social media by searching for Beyond Clean and Transmission Control.